All right, we're going to go ahead and get started. I think we have some more folks who will be coming in throughout the event. First of all, thank you for being here on a spring day in May at Dartmouth College. We thought 2 people would be here, so thank you for being here. I'd like to get started with a talk that Dr. Dan Lucey and I have been scheming about for quite some time. It's called The Physician Advocate, Healing During the AIDS Epidemic. One thing you'll notice about all of us is this general age range. And one of the things that we talked about was how people in our general age think of HIV and AIDS in a very different way than students of today or even 10 years ago. And we wanted to use some of the arc of the story to explain not only the intensity of that time and the horrible stories, but also the great stories that rose out of that. But we also wanted to really touch on how the clinical side of HIV was also really powerful in the advocacy side of fighting against the disease and how that happens to this day, not just with HIV, and use that as a exemplar as we all go into our clinical or paraclinical lives going forward. I want to talk a little bit about one of the other things that Dr. Lucey and I discussed, which is he just got approval for a course next fall called MALS 218, A History of HIV/AIDS and the Humanities, Part 1. I love that. It's like a Mel Brooks movie. You know, it has that feeling to it. What we discussed was using this panel as a springboard for some of those conversations and what that looks like. So much of disease really lives in the conversations that you have in the clinics or in the pharma industry, and we wanted to lift it and include some other voices. And this was, I think, in a way, almost like a pilot for this. So look for that. It will also be cross-listed in the English department as well for undergraduates, if that's something you're interested in. So the goal of today is really making room for the kinds of advocacy that these 4 people represent. There are 4 different storylines that we'll discuss. And before I have each of them introduce themselves, I want to give a little, almost a timeline, a very high-level timeline of the history of HIV and AIDS, mostly with the U.S.-centric focus, but just so you have almost a structure to hang some of these stories on as we go through. So in looking at blood samples later on, it shows that in 1959, there was a gentleman in the DRC. That's the first evidence of HIV, the human version of it. They've had some conversations. They've been able to model that it crossed over from a simian version of it back in the 20s, I think. But that's really when the first time it showed up in humans. In the 1960s is when it really rose in prominence for Haitians who had been working in the Congo and seemed to have brought it back from them when they came back to Haiti. 1981 is really when it started showing up in the United States, and primarily in the gay population, the male gay population at that time. There was a rare form of pneumonia that was showing up amongst some other diseases that they couldn't really pin it to anything else, and that's when they really recognized that as something that's they then called AIDS. In 83, they actually identified the virus that was responsible for that. Middle of the 80s is when some of both the testing for it and some of the earlier drugs were developed. And it's not till really the mid-90s that some of the more effective long-term drugs, a little bit easier to live with. Sometimes the drugs killed you before the disease did in earlier stages. These were more almost what I think of as chronic disease, treating it as a chronic disease drugs. And then we moved to the 2000s where we now have advent things like PrEP, where you have pre-exposure drugs now. So, and that's something that we'll probably dabble a little bit into as well as we go through. So is there any big element that I've missed? It doesn't matter. You guys are going to fill this out in a way that I never can. I love this. Okay, so again, as I said, I'm going to have each of the panelists give a little chat about introducing themselves and what brings them to this work or brought them to this work in the beginning. And then we're going to circle back with some questions, both from me and from you and from all our folks online. Thank you, online people. So, Jim O'Brien, could I have you start? Introduce yourself and tell us a little bit about your part in this story.
So I need to start by saying I'm a medical oncologist. I've been a medical oncologist for 35 years. I specialize in hematologic oncology. I've not been actively involved in the treatment of AIDS for many years. I graduated from Dartmouth Medical School in 1981. Dan and I were classmates. And I left this kind of serene, bucolic environment in 1981 to begin my internship in a big city hospital in Lower Manhattan. In fact, in the center of what was either the biggest or the second biggest population of gay men in the country. I began my internship on July 1st, 1981, and on July 3rd, first night I was on call, an article appeared in the New York Times, which was, I think, recognized as the first description of this phenomenon, written by Lawrence Altman, who was the science reporter for the New York Times, and Dan and Larry and I have actually talked about this in groups before. So I'm sort of, I guess, what a lawyer would call a witness in fact. I lived through the evolution of this, and from the beginning of the very first cases that were coming in up to, interestingly, the discovery of the virus at the end of my internship, and then I went from there down to the National Cancer Institute, where a lot of work was being done. In fact, the first clinical trial was done, and purely serendipitously, I enrolled the first subject in the first clinical trial of an agent specifically used for treatment of HIV. I don't know how far you want to go into detail right now. I can talk about that early era, what it was that we were observing, or we can get into that later as.
Either way, sure.
Well, I can. I think the biggest revelation was. What we were seeing things that were completely unexpected. I think there was a certain level of confidence we had in 1981. Maybe the word is arrogance. We had genetic engineering was just happening at that time. The whole area of molecular biology was kind of burgeoning, and we thought we really kind of understood things. There were first recognition of oncogenes, so we were beginning to understand cancer in a molecular, primitive understanding of cancer in a molecular way, and then we started seeing these very highly unusual events, and generally in very healthy, athletic young men would come into the emergency room, and the one case which Dan and I talk about a lot, which I remember, was a young man who came in and he was complaining of shortness of breath, and we took an X-ray. His X-ray was perfectly fine, and sent him home. I was working with a senior resident who was a very smart guy in pulmonary medicine, and thought, well, this may be early asthma. We sent him home. I was then came back 2 nights later. I switched to the night shift in the ER. When I came in, this same guy was now back in the hospital, and he was being intubated, which means being put on a respirator. He, within 2 days, had progressed to acute respiratory failure, and his lungs were, the term we use is whited out on the X-ray. And within a few days, we get a diagnosis of pneumocystis pneumonia, and it was, everyone knew pneumocystis pneumonia because it's one of those things that you learn about in medical school and never, ever expect to see again because it occurred almost exclusively in children with acute leukemia who are on high doses of steroids for long periods of time. So it's a board question, what we call in medicine a board question. And here is this healthy, athletic, well-appearing young man who quickly develops pneumocystis over a couple of days, rapidly progresses over a few weeks to respiratory failure and expires. Another case, again, a young man who was a bartender in a local bar. People sort of knew him. He was admitted to the hospital with a deep vein thrombosis, and he was treated, released a couple of days later, comes back about a month later, again has a deep vein thrombosis. He's a very kind of social guy and fun to have him in the hospital, and being young and gregarious as compared to people who are chronically debilitated, and is discharged, comes in about 3 months later with an acute seizure disorder, and we do a CT scan of the head, and he's got multiple lesions within his brain, and biopsy's done, it's toxoplasmosis. We say, well, that's not supposed to happen, right? We don't see that kind of thing. A young man comes in with progressive diarrhea over a week's time, is hospitalized, and really debilitating, if you can imagine, just severe diarrhea 24 hours a day continuously, and nothing could be done. The diagnostic tests were uninformative until someone had developed this novel methodology, and turns out to be cryptosporidiosis, which is a disease of cows. Until that point, that wasn't even a board question, because that's a veterinary board question. Yeah. And we began to recognize that this is really a profound phenomenon that's happening. I mean, it's interesting when you see something for the first time. By definition, you have no historical experience that informs your thinking about things, right? These were things that just were not supposed to be happening, and it got to the point that we would see these young men come in, and again, young men, because that was the population that we served largely in this hospital, and you just knew that what the course was going to be. You could almost plot it out. And I remember seeing one, again, young man, same demographic, who came into a dermatology clinic. And I think the reason he came to the dermatology clinic was that he was so worried, he figured, well, but if I went to a dermatology clinic, it couldn't really be serious, right? So if I go to, and he was worried because he had this white coating in his throat. It turned out to be thrush, which is a fungal infection, Candida infection that you can get if you take antibiotics or whatever. But here he had no reason to have this, and by this point we recognized that here was this young, healthy person who walks in and has this finding, and we knew that this really, for this person, represented a death sentence, that it would progress, and we began to recognize there was a prodromal phase where there was enlarged lymph nodes, and then the lymph nodes would disappear, and then there would be this progressive immune deficiency. I want to just end with one case. I had gone to the National Cancer Institute, studied oncology, and went up to Memorial Sloan Kettering, where I was an attending physician on the lymphoma service, and this was about 1995, 96, I don't remember the exact year. And I was treating a woman recently diagnosed with Burkitt's lymphoma. She was an intravenous drug user, was HIV positive, and had gone through this period of pretty rapid progression of her lymphoma, and had a bone marrow biopsy was done, and that became super infected with Pseudomonas. So she had this wasting syndrome, this progressive lymphoma, fevers, and this weeping, draining abscess on her back. And this was just when the highly active antiretroviral therapy became available. And we started her on this combination of drugs, and saw her back a week later. The infection was completely healed. The Pseudomonas infection was healed. Her lymphoma had shrunk down. She'd gained about 5 pounds of weight. And it really was just a remarkable, I don't want to say experiment, a demonstration, really a demonstration of the importance of the immune system, the power of the immune system when you can restore it, how much healing happens so quickly through the immune system. We were used to seeing this with chemotherapy suppressing granulocytes, which fight bacteria, but when you see that people would have bacterial infections and their granulocytes would recover, and these infections would go away very quickly. But to observe this with T cell recovery and the efficacy of T cells in fighting infection was really quite remarkable. So I'll stop at that point.
There'll be more. There'll be more chances, as they say. Jeffrey, if you want to introduce yourself, I'm loving the element that you're discussing of surprises, both the good surprises and the unicorn elements of it as well. Tell us a little about you and what brings you here into this work.
You do. To this work. You brought me into this room. Bless you.
Thank you.
My name is Jeffrey Fennelly. I'm a Dartmouth class of undergraduate, or BA, class of 86, Columbia School of Social Worker, class of 02. I left Dartmouth to be a teacher and to be out. That's all I wanted. I wanted to be out. I wanted to be free. It was a tough time in the 80s. The summer before I came to Dartmouth, a certain element on campus had stolen the list of the Gay Students Alliance roster, and published it. And so that sort of, and then my senior year, there were some other not nice things that happened. So for someone who wasn't sure where he stood in the world because of his sexuality, Dartmouth was all the things that it is, which is just a glorious place, an Eden, and in a lot of ways a hell. I just wanted to finally be out, and I knew I wanted to be a teacher. I loved poetry, I loved literature. Didn't matter that my dad was a doctor, my two brothers were in medical school. My dad gave me his blessing. He said, I'm happy one of my kids isn't going to be a doctor. So I scrambled. I tried to get a job at all the elite private schools in Manhattan, and I got about 20 rejection letters. And then I decided, well, why don't I try the West Coast? Because I wasn't gonna go live in Rutland, So San Francisco Day School accepted me. I got a job 3 days after graduation at the San Francisco University High School, teaching inner city kids, prepping them for high school. The eve of my departure, my mother said, go say goodbye to your Aunt Anne and go say goodbye to so-and-so. I said, fine. 60 Minutes had just run their episode on San Francisco and AIDS. So my Aunt Anne, who wasn't really my aunt, she was just a friend of the family's, said to me, it's a good thing you're not a queer. I just saw this thing on TV. They're dropping like flies out there. Have a good trip. My friend's mom said to me, honey, keep it in your pants. It's a seething cauldron of death. So that was my introduction to really the world of adulthood. You know, most of us think of adulthood as when you graduate from college, it's all opportunity. And it's a lot of things to be afraid of. But dying young, that wasn't one of them. So I got out there, and ironically, or whatever, serendipitously, my first host family, I had to live with host families, was a Dartmouth graduate, and he let me drive his BMW over the Golden Gate Bridge. So there was this whole part of San Francisco that was like Dartmouth, in the sense that it was a fairyland, you know? I mean, literally and figuratively. And then after I started teaching and I kind of established that part of my world, which I knew was super important, I started to date. I started to go out, and I was terrified. I had a roommate who sent me to a Stop AIDS Project meeting, and I learned what was safe and what wasn't. And then I went to my assigned doctor, who was an oncologist who didn't have your heart, doctor, and said to me, when he found out I was gay, find somebody who's negative and stay with him. And my thought was, it's easy for you to say. You know, go find somebody with blue eyes, you know, who's a size 34 waist, who has never had a cold, et cetera, et cetera, et cetera. Well, 1987, when I was still 22, my boyfriend, who was, you know, he's still the love of my life, we were on a date and he was acting funny. And I said to him, put down your pizza, we're going for a walk. And he revealed to me after we'd been together for about 6 months that he was positive. And we were having trouble anyway, but I started to cry, which I wish I hadn't. But I said to him, this isn't about that, it's about us. And if we end this, it's not because of the HIV, which I'll never know if that was the truth. You know, it's like, how many licks does it take to get to the center of a Tootsie Pop 3? So I lived in San Francisco for another 3 years teaching, and I had the opportunity to go back east in '88, fall. And somebody said, you know, you missed last year's March on Washington. Bush is still president, or it was Reagan, I guess, at the time. Reagan was still president. And I hear there's something going on, LGBT related. Well, it ended up being ACT UP storming the FDA. And that's when I knew what I wanted to do with my life. I was not going to be afraid anymore, and I was going to move back to New York, and I was going to be an activist. And I spent the next decade and change doing activism and teaching on the side. And at one point, the New York Times had a front page story below the fold, Sunday, revealing that the most dramatic increase in new HIV infections, I think this was 1990, was among youth in New York City. And I called ACT UP, I called the hotline, and I said, this is bullshit. I need to be on the floor tonight. They said, oh, we just got a call from Eric Epstein. He's a teacher too. Eric and I stood on the floor and we called for an action to get the condoms into the schools. And fortunately, we got our spiel out before Larry Kramer accused me of being a murderer, because I was focusing on education and not a cure. And so I have that badge of honor that Larry accused me of being a murderer, along with, you know, many other greats. And I guess about 4 months later, after rallying, all these kids joined us, and we would show up at high schools with condoms and literature, and finally we got into the school's chancellor's office with Sue Simmons from the 5 o'clock news, and about a week later, to his professional peril, he made it happen. And I'm now a social worker in the public schools, and I just went through my 22nd condom distribution training, and I didn't let anybody know why I was, my claim to fame. The 90s weren't fun. The 80s weren't fun. The 90s weren't fun. I became a social worker, I think, because the prospect of not surviving, even though I'm actually HIV negative, but I had a series of boyfriends who were not. Last of which I discovered his Hickman catheter when I took his shirt off for the first time. And he told me he wanted to marry me because I kissed it. And I said, does that hurt? Because I knew what it was, because all my friends in my 20s were getting sick. But I had one friend in particular who was telling me about this course in death that he had been to, taught by Ganga Stone, who started God's Love We Deliver. And I said something like, you're not going anywhere. You're immortal. And he said to me, Queen, you don't even have it, and you're more fucked up than I am about this virus. So he introduced me to a community of people who were preparing for their own death. And I was humbled and empowered. I realized that the reason I didn't get tested for 7 years, because the prospect of acquiring HIV in my family, it just wasn't okay. That's what I thought, because they were all healthcare providers. And I wouldn't go to a doctor who was an HIV specialist because I thought it was a catch-22, because I thought that I was stealing time from the people who needed him. And so I saw his PA for like 4 years, and I didn't trust him enough. And the catch-22 was I needed somebody who could take care of me. So, I mean, it was such a twisted time in so many ways. I mean, granted, I think the worst of it all was, for the majority of my young adulthood, the people in power really didn't give a shit if we lived or died. Pardon my non-Dartmouth language, but I was brought up by Larry Kramer in some ways. So, but they really didn't care if we died. And it wasn't until 1996 that we realized we probably weren't going to. And 10 years is a lot of years to live thinking you're going to die. So I decided around that time that I was going to take care of young people and help them onto their feet before they stepped into the maws of another worldwide surprise like this. So that's what I do today. Sorry.
Don Avery, you're supposed to share yours with Dan. You two share? Yes. We talked about this for 20 minutes, so,
Dan's hasn't been used yet, so I'm going to go. First of all, I'm really grateful to be here. I'm grateful for this conversation because I feel like the history is so important and it's easily lost, easily forgotten. So my journey began with this epidemic in 1988. I was not a Dartmouth student. I'm sorry. I went to NYU. But in 1988, at 19 years old, I was diagnosed with HIV. So next month, let's see, June 28th, it will have been 36 years.
Yes.
36 years since I was diagnosed. So I've had a bit of a front row seat, and not one that I wanted, but on many levels, one that I'm super grateful for. So when I was diagnosed, life expectancy was about 6 months, because everybody was being diagnosed then was being diagnosed in those really dark moments where nobody knew what the heck they were dealing with. And so my first goal was to be 20. It was a big goal. I was the only woman I knew in the world. I grew up outside of Atlanta, and so I was diagnosed by an infectious disease and internal medicine doc in Atlanta, and I was the first woman he had diagnosed. And he said, don't read anything, it's too confusing, and don't tell anyone, because this could really ruin your family's life. Your brothers could get kicked out of school, your dad could lose his job, your family could lose their insurance. That's what it was like in 1988. The other thing that's really important about 1988 is that it was 10 years before Google. So there was no Googling what's happening right now. There was finding medical journals and newsletters and trying to find other people in the community with information, of which there was very little. So I spent my first couple of months in this really dark, scary place. Despite the great advice from the doctor, who I think was doing the best he could because he didn't have anything to offer me at the time, I went home and I told my younger brothers. Now, I was 19, my brothers were 17 and 15. And we had all had about 20 seconds of health education. It's also taught by the football coach. I don't know if that's still true everywhere, but in Georgia, that's the way it was. And it went something like this. There's this disease called AIDS, and as long as you're not an IV drug user, a prostitute, or a gay man, you have nothing to worry about. Next STD. And it had moved on. So I went home to my younger brothers and said, I just found out that I have HIV. And both of them just kind of sat there and looked at me like they're pretty sure I'm not a gay man, and they're trying to figure out when I became one of the other things. And they had very different reactions. The one who's 16 months younger than me went tearing upstairs to the encyclopedias, and every 15 minutes, like clockwork, came running downstairs telling me all the ways it could be worse. By the way, it couldn't have been worse. There was nothing worse in 1988 than this death sentence, which is exactly what it was called. We sat as a family around the dinner table, and somebody turned on the news, and they literally talked about HIV and AIDS as a death sentence. The other one completely shut down. And, I look at him now as an adult over 50, and I think, wow, that really totally perhaps changed the trajectory of his life, not just mine. So I decided that if I only had 6 months to live and I went back to school to finish my degree, maybe it wouldn't count as time lived, like, I don't know, some weird purgatory or something. But the doctor and I feel so bad for him now when I think back on it, but he said, I don't think you should go back to New York. I don't think you can handle the harsh winters. I know I live in Vermont now. So I transferred in to Emory and then Georgia State very quickly and came back home to where my parents were. I somehow managed to get a degree and took my first job in Washington, D.C., working for a very high-profile U.S. Senator, Senator Sam Nunn. Probably most people in this room are not old enough to remember Senator Sam Nunn, but he was kind of Bill Clinton's leading opponent to the gays in the military. ACT UP and Queer Nation had decided that this was bigotry and it was all about AIDS. And one day I was standing in Sam Nunn's office. I had Saturday duty because I worked in the mailroom. I was a very highly qualified staffer. And ACT UP and Queer Nation showed up at the door with fake vials of blood. And so these were these advocacy organizations and, ripped jeans and T-shirts, and I'm standing in my pumps and pantyhose in the senator's office, and they're looking at me and they're saying, you're a bigot, you hate people with AIDS. And I'm like, no. I don't hate you. We're not afraid of you, but I couldn't tell them. And I think that moment was incredibly pivotal for me. It was this moment where I realized that I had come to Washington partially because I didn't really truly believe that anything could be this dysfunctional, and I verified that in fact it was. But I also learned how decisions were made and who made the decisions and where power lived. And it was an extraordinarily important couple years for me. But that what I really wanted to do was work, I hate to say it, on the other side, but to work in the community and start to, now that I understood who was making the decisions, leverage that. And so I got my first job in Atlanta at the AIDS Survival Project, which was a grassroots AIDS service organization. And I tell, there are many, many stories of which I will not regale you with all of them, but I walked into this interview to be their treatment resource specialist. I knew about 5 things about HIV. I knew I had it. I knew more T cells were better than less T cells. I literally knew nothing. But I had stayed up all night and memorized the opportunistic infection chart. So I knew which infections were viral, which ones were parasitic, which ones were protozoal, which ones were fungal. And I went in there and I started spewing this out. And there was this panel of what I fondly refer to as beleaguered queens sitting in front of me in my pumps and pantyhose again, because I had just come from Washington. And they're all kind of looking at me sideways. And one of them finally says, "Why are you here?" And I had to, for the first time, in front of a group of people who I didn't know, say, "I have HIV. This is about me." And my friend Tom, to this day, says, we either thought, "Oh my God, she's a pathological liar," or we've just hit a gold mine. So somehow, for some reason, I convinced them and they gave me the job. And I spent the next year building the biggest treatment resource center in the southeastern United States, which in those days involved 3-ring binders and 3 punchers and photocopies of journal articles broken down by the kind of topic area. And in that period, I also found myself, because I was a little bit of a weird unicorn at the time, I was an HIV positive white woman from the South who was interested in the science. So I was a sort of an anomaly. And I decided that I really wanted to understand what our actual options were. When I was diagnosed, my doctor had no idea what to do. So what he said, "Let's just try this one thing. I'm going to give you AZT." In 1988, there was one drug to treat HIV. It was AZT. And we used it all wrong. It was dosed at 1,200 milligrams a day, 2 every 4 hours, 24 hours a day. So that meant setting your alarm for midnight, 4 a.m., 8 a.m. It made me sick as a dog. And I thought, oh my God, I hope I never have to take this medication again. Fast forward now to the early 90s as a treatment resource specialist and somebody who's working on the science and trying to drive clinical trials and understand the medications and what they're developing. And simultaneously, my health was kind of tanking. My T-cell count was dropping through the floor. At the time, you got an AIDS diagnosis when your T-cell count dropped below 200. Mine hit 74 in July of 1994. And because I was an activist and because I was finding my way into FDA meetings and NIH and ACT UP and chaining myself to things and doing all of the things that we did in those days, I knew about a clinical trial for one of the protease inhibitors. It was happening in 4 places in the United States. I lived in Atlanta. The closest one to me was Albany, New York. And so I figured out how to get a plane ticket to Albany, New York, and go up and screen to get access to this medication, because at this point, I was losing 50% of my CD4 count every month. My T cells were dropping, and I was in a very big danger zone for all of these horrible opportunistic infections we were hearing about already. And I flew to New York. I screened for the study. A week later, they called me and said, "I'm really sorry. Your T-cell count is too low." It had to be 150. And they said I had 126. So I said, my first real act of activism, I was like, "So how many women do you have on this study?" In a really big voice. And they said, "Just a minute." And they talked to each other and they came back and they said, "We don't have any yet." And I said, "Please test me again." I was very sick when I came. I had a flu. So my whole premise was my system was compromised and you should try. Again, I took every drug that was available for 3 weeks, and echinacea and every kind of home remedy you can imagine. We were injecting mistletoe extract and taking megadosing vitamin C. I was miserable to try to get my T cells up high enough to get on this study, which was kind of my lifeline. So I flew to New York, and I went back to Albany Med, and I went through the whole screening process again, and I went home and I waited. So this was 1994. This was before the kind of panacea of the new classes of drugs and the combinations. And in an aid service organization, we had people dying every week because they didn't have access to these medications yet. And so we had somebody coming to the organization to do a training on grief and grief counseling. And just as the person had arrived to give the whole organization their training on grief counseling, the phone rang, and it was a nurse from Albany Medical Center. And she asked for me, and I got on the phone, and she said, "Dawn, I'm really sorry. Your T-cell count still wasn't high enough. It isn't going to work." And I hung up the phone, and I looked at my colleagues who were all standing there like this, and I said, "That's it." Basically, I lost the lottery. And I said, "I don't think I can stay for grief counseling right now, and maybe I might just go lay in the street." And I was about to head out the back door, and the phone rang again, and somebody called from the front office and said, "Dawn, there's a call for you." I said, "I can't talk to anybody right now." Tears running down my face. They're like, no, you need to talk to them. I picked up the phone. It was the principal investigator from Albany. And he said, "I have a dyslexic nurse. Your T-cell count was 162. You're in. You have to come next week." So that began my journey on my first clinical trial. We can all reflect on what actually happened later. But every week, once a week for 12 weeks, I flew to New York to be a clinical trial participant, and then every other week for another 12 weeks, and then once a month for a couple of years. But about 5 months into that, my T-cell count was at 200 or 300 and climbing. My viral load was undetectable. It had been 750,000 copies when I started the study. And in 1996, the drugs were approved. The first of the protease inhibitors were approved. December was the Roche drug, and in March was the Merck and Abbott drugs. It was kind of ding dong, the witch is dead. It was a crazy, exciting time. People were getting up off of their deathbeds, and we thought it might have just solved the problem. That was not the case, but it was an extremely exciting and important time. The story goes on and on and on. I told you this is 35 years of story, so I'm going to stop by telling you that in 1998, still on a multi-drug combination, I took my last break from medication. So it's been solidly almost 26 years. And I've had an undetectable virus and a T-cell count that looks completely normal, over 1,000 CD4 cells, which we never thought was possible. I'm the mother of three daughters. Also not possible in those days. It's been an extraordinary journey, a lot of fighting, a lot of partnering, a lot of advocacy, a lot of tears, a lot of pain, a lot of saying goodbye. But I feel like every day it is my privilege to be someone who can now share that experience and the kind of unbelievable set of learnings that helped us do things like prop up a COVID vaccine in a very short amount of time because of a decade plus work that actually happened in HIV before we were trying to figure out how to address the coronavirus. So I've had a front row seat to a lot of that, and I am incredibly grateful, and I can't wait to hear your questions and have a broader conversation.
Thank you, Dawn. Dan Lucey.
So first I'd like to thank Don Carey and the John Slim Dickey Center for organizing and hosting the meeting here this evening and for recording it for posterity. And secondly, I'd like to thank Jim, Jeff, and Don for their sharing in deep, what the French call témoignage, sharing what you've learned with other people. So I'd like to be fairly brief for the past 42 years, and I would encourage you to take my course, which starts September 17th, every Tuesday afternoon, and for 10 weeks, and I can share more then. But basically, Jim and I were, as he said, we're medical school classmates here. I graduated from college in 77, then rode trains in Europe, and then hitchhiked to India from Istanbul, and got into a lot of trouble in Iran, Afghanistan. This is back in early 78. So little did I know that was a wonderful training for becoming an epidemic investigator or fighter, which I learned from working in HIV for the first 20 years of 1982, my first 20 years. The virus was already quite old. It found us long before 59 and started the pandemic, but we didn't recognize it until decades later. But all this traveling was a wonderful training for feeling comfortable traveling to different countries by myself. And then finally I could give something back, which I didn't start doing until 2003, by going overseas every year to different epidemics like SARS and MERS and Ebola and Zika and plague, et cetera. And I just got back this afternoon from Kansas. So Kansas, I think there's something not good happening with influenza A outbreak that's unexplained still after multiple weeks. But also going to Kansas, I attribute that directly to graduating in 1982, driving cross country to San Francisco. I thought I was going to become a sleep researcher, a neurologist. I'd worked at college for 2 years as a work-study student in a sleep laboratory as a technician. Patients would try to sleep, they couldn't, and I would stay up as a technician, I couldn't sleep. But that all changed within the first 2 or 3 months being in San Francisco in the summer of 82, because we had many patients, much like Jim had experienced a year earlier in 81 in New York City, with this unexplained disease that was rapidly fatal, almost always. We didn't know what caused it. We didn't know if we would get it. Back then at San Francisco General Hospital, which is very different than the current version, Zuckerberg San Francisco General, it's much, 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 much nicer. It's a county hospital. I used to say perhaps, irreverently, that no patients would go there unless they had nowhere else to go. So in a sense, it was a great way to learn responsibility as a young intern physician to, do the best you could to take care of the patients. And I'd say there's something unique in San Francisco 82 to 83, which I imagine is similar in New York City in 81, 82. And that is, it was a brand new disease. It was rapidly fatal. It was actually Jim who taught me about patients who could come in and say that they just have shortness of breath. The chest x-ray looks normal, but that's because the chest x-ray couldn't see the abnormalities until then, 48 hours later, the patient would have to be on a breathing machine. So I remember that when, July of 82, I had patients like that came into University of California, San Francisco General, and the VA hospital. It was all one big training program. But even so, I made mistakes where the patient was short of breath or we suspected pneumocystis pneumonia. But until you've seen it progress in 24 to 48 hours to the patient having to be on a breathing machine, you just don't appreciate what that means. And what it meant for me as a brand new medical intern was that you have to talk with the patient the very day and or night they come into the hospital and they become your patient about who do you want them to talk with about their illness. And often that was, there's people, but I can't tell you who they are, which I didn't understand for the first month, and then I understood after that forever. But also you have to address with the patient, if you need to be on a breathing machine, do you want to be on a breathing machine where they put a tube down your throat, you can't talk, you can't really do anything? And back then, a lot of times you never got off the breathing machine if you had pneumocystis pneumonia. And also, do you want to be resuscitated, or do you want to undergo what we call heart-lung resuscitation, cardiopulmonary CPR resuscitation, which again, more than half the time, you don't survive. And so it's a very painful way to leave this earth. So after making that mistake once and not doing those things the first day or night with the patient who had pneumocystis pneumonia, then I always did it. And for me, it inculcated this sense of duty or responsibility of anticipating what might happen and being thankful if it didn't, but anticipating what might happen, recognizing it as early as possible, and it started to, and recognizing what needed to be done, what actions you had to take to try to prevent the patient from becoming very sick, going to the intensive care unit and or dying right there that night. Maybe you're not even on call. And that's really stayed with me the rest of my career, 42 years. So I used to teach before I came back here after 40 years, literally in the wilderness, 1982 to 2022 before coming back. Used to teach at Georgetown in DC, lived there for many years, decades. Also didn't think it really could be as bad as, but it is. Georgetown students asked me once, could you just distill down all of your, back then it was whatever, 38, 40 years into like one lesson. That's the most important lesson. I say, well, no, actually. And I have this list of 40 lessons, one for each year. They go, that's nice, thanks. Could you just leave it by the door? We'll pick it up on the way out. What about just one lesson? And, you know, it's one of those things where you think, well, I can't do that. But when you have to do it, you know, it's like when I came back from Ebola in 2014 in Sierra Leone and Liberia working with Doctors Without Borders, there are various organizations and people in DC. They said, can you just come talk about, you know, the very most important thing? And you only have 5 minutes. And literally 5 minutes. So San Francisco, there was a huge meeting on April 2nd of 2015, 300 people in the room. It was a big auditorium, convention center or something. And the person who organized it used to work in the Clinton White House. And she says, this is the way we do it. Just the way it's done. You got 5 minutes. You go to the mic and there's a giant red clock and it says, you say, well, hi, my name's Dan Lucey. And the clock goes down from 5 to 4:59 to 4:58. It's like, okay. And then you realize, you know what? It's an honor to be here. It's an honor to have 5 minutes because you're speaking not for yourself, but for many colleagues, many patients. So anyway, so I came up with one lesson and it's 3 words. They're all verbs. And it's simply from 1982 really on. And it applies to epidemics, it applies to clinical, non-epidemic work, to some extent even laboratory work. And the 3 verbs are anticipate, recognize, and act. That's it, anticipate, recognize, and act. So there it is. So I could probably stop right there, but let me just say one more thing. So all infectious diseases you can think of and should think of, in my view, as 2 armies. And it's a war. And one army has all these infectious diseases, and the other's all the parts of the immune system. And when you take away the immune system with the HIV virus, then you become susceptible to the, it sounds bad, I don't almost like want to say it, but it's really like a swarm of infectious diseases. Some parasites like cryptosporidiosis, some bacteria like Pseudomonas or tuberculosis, and we have Dr. Adams here as the world's experts on HIV and tuberculosis, dual pandemics. Fungi, which we thought was initially a parasite, pneumocystis, et cetera, et cetera. So often you have multiple infections when your immune system is destroyed by HIV. It's not just one thing. What we learned in 82, 83 is that our teachers couldn't teach us about this new disease because they hadn't seen it. Everything else, everything. Heart, lungs, skin, everything, brain, they could teach you about it because they'd seen it for years and decades, but not this new disease. So you go to the library, and even in the medical literature, it wasn't there. Or you'd say, well, I have a patient with a new infectious disease, or tumors. There were at least 6 tumors, different kinds of brain lymphomas, Kaposi sarcoma, which primarily involved the skin, but sometimes the heart and lungs, and liver and spleen, that were all basically AIDS defining. But the teachers couldn't teach you about it. And I hope that never happens to anyone else in the medical field or otherwise, but we didn't ask for it, we didn't expect it, but it's important to recognize it and do the very best that you could to help your patients, but also then to teach other people. So as a second year resident, I tried to teach everything. I wrote on the board one time this new intern from Johns Hopkins, and he says, well, we're not seeing this on the East Coast. I was like, well, they will, and you will today and tonight and tomorrow and the next day and the rest of your 3 years here. So the last image that I want to leave you with is quite stark, but it's something that I don't have to try to remember because you can't forget it. So as an intern, you get 2 weeks vacation, and the other 2 weeks in that month, you get an elective. This is the bad old days, 1982, San Francisco General. And so they said, what elective do you want to do? I said, well, I want to do the new AIDS clinic. They're like, okay, nobody else has done that. Like, really, you sure you want to do that? I said, oh, yeah, I want to do that. So January of 83, San Francisco General, each day of the week, Monday, Tuesday, Wednesday, Thursday, Friday, you come in and it's a room this size, and it's patients who have AIDS, but they all have one specific manifestation, either a tumor or an opportunistic infection. Opportunistic means because the immune system's been destroyed, otherwise it wouldn't be happening. So you walk in, and Monday, let's just say it was Kaposi sarcoma clinic day. So you walk in, there might be 70 men, 82, there are no women. There isn't, I looked hard for women, there were no women. It was all, and then we had no blood test. The virus wasn't discovered till the next year in 83, and then the antibody, 84, 85. So Kaposi sarcoma, you walk in, and back then, Kaposi sarcoma, it was impossible to hide. Often it was in multiple places in the face and the hands. And then Tuesday, you walk in, and it's people who've survived pneumocystis pneumonia, but are on preventive medicines now, sort of like a prophylaxis, almost like a prep for pneumocystis. And Wednesday, maybe it's cryptococcal, a fungal kind of meningitis, people that have survived that, but they're on lifelong, permanent, back then, treatments. And then Thursday and Friday would be other diseases. Extremely sobering. So that's why I went into infectious diseases and really focused on HIV for 20 years, but then other epidemics, and go to them every year overseas, except for now going to Kansas. So
Wow.
that's it.
Thank you. So you're getting a basis of what each of these people brought to, or how they were brought to this work. And one of the things that came up with each of your stories, and this is because I have a fable mindset in general, there are heroes and villains in this story. Each one of you mentioned someone who might have been a hero. I guess Larry Kramer's kind of both a hero and a villain, but a hero. I'd love each of you to tell me someone who showed up as a villain in your storyline, and how does the world look at them now? How does those elements of it? Was there a change? Was there a shift? I mean, I can think of a couple that come up right now. Who wants to jump in? Yeah, grab a mic if you're gonna, yeah.
As I was driving up here, I was listening to How to Survive a Plague, just to get into the head of it. And I hope the building doesn't fall in on me, but Ronald Reagan. And his entire administration and that entire trajectory of denial.
Can you spin that out? Because
Sure.
we know what you're talking about.
Sure.
But I think describing it.
It's really interesting because I'm just trying to think. Bob Rafsky died Bob Rafsky was one of my heroes. There's so many of them, and he was in the TAG. He was in Treatment Action Group, which is basically responsible for taking the mess that was the bureaucracy in DC, the NIH, and these guys met at the NIH, and on the bus ride back, they came up with a plan. They mapped out a plan for research and development. And Bob Rafsky said he was crying because he was at, I think it wasn't Bob, it was Greg Bordowitz. It was in '96, and it was the three talking heads, Peter Staley, Greg Bordowitz, et cetera, and they were saying how they were going to survive. And they all had said earlier in the film, because it's done in real time, there were videographers, that they weren't going to survive this. And they're crying and they're saying, but it could have happened earlier. It could have happened sooner. 4 million people didn't have to die. And earlier I had seen a clip of Peter Staley being very measured about Ronald Reagan, and he said, the moral majority was his base. And one of the reasons he didn't even mention the word AIDS until 1987 was because he didn't want to offend his base. And when you think about that, you think about how we subjugate facts for success. Ram Dass, who was Richard Goldstein, Dartmouth of 1972, spoke to us during the Clinton campaign at some meeting. It was more of a healing group than an ACT UP. It certainly wasn't ACT UP. And he said, be careful of the ends justifying the means, because it'll always come back and bite you. And so Ronald Reagan he could have done so much. He could have done so much. Poor Anthony Fauci was cowed by him at first. And he was grateful to Larry Kramer, who called him a murderer on Nightline, and then called him 15 minutes later and said, wasn't that a great show? Which it was, because Fauci paid attention. Fauci was human. Fauci was a scientist. And so he was a villain for a moment who became a hero. But there were countless. I mean, somebody said to me the other day, everybody in government who had a mouthpiece didn't care if you lived or died. And so there were so many villains. Like I said the other day, there was a villain du jour. I don't know if I fleshed out the Reagan years enough for you, but it was a time when you just didn't mention stuff. And there was one little anecdote that I have to share that I learned on the 25th anniversary of AIDS. They were burning houses in Florida of hemophiliac kids who were infected. And Reagan was poised to make a 9 o'clock, not quite primetime speech, where he finally mentioned the disease and he finally spoke about how it was spread. The spokesperson for the NIH wrote the speech. She handed it to him. His head legal advisor, head legal counsel, who was a fundamentalist, read the speech, tore it up, watered it down, and Reagan basically didn't give the information that could have saved hundreds of thousands of lives. And that man's name is John Roberts. You can Google it. Frontline. So when we're talking villains, we're talking, villains.
I want to talk about a hero, or heroes, a group of heroes, who always go unmentioned, and that is the nurses who took care of these patients, right? You have absolutely no idea what these, mostly women, what their lives were like on a daily basis, and they did not shy away from it. It's kind of like the firemen on 9/11 running into the burning building. But it's just really a special group of people, because we, as physicians, we go in the morning, we go in the afternoon. We have the big conversations, the important, but the people who are there 24 hours a day, really 8 hours at a time, 9, 10 hours at a time, changing the bed sheets, cleaning up the various bodily fluids. These are just amazing men and women, mostly, although I have to say mostly women. So I just say that since you brought up the heroes, the unsung heroes, really quite, and a remarkable group.
And the parallel to our recent pandemic is not lost on me on that. Thank
Well,
you. Yeah.
I think that's true.
Yeah.
I think that's true. I think it's not a perfect parallel, though, because I think you just have to realize that this environment that they worked in was a horrific environment, because of the lack of control of bodily fluids and all the unknowns, right? Unknowns. I mean, I think for all of us at the time, there came this point. There used to be something called the 4-H Club, right? It's a bit of a pejorative, but it's history. It's not making this up. But it was the groups that were identified as at risk, right? And you remember this, right? So they're hookers, Haitians, heroin addicts, and hemophiliacs, yes. And then, a group of us were sitting around watching the news in the ER, and then someone says, and house officers, the 5th H, and then everybody realized, holy shit, And we were really very careless back in those days with bodily fluids. We'd have, you'd have blood on you, and you weren't careful with needles. It was really a very different time. There was that point, but people those involved in caring for patients, acutely ill patients, they said, wow, we could, we can get this ourselves. And that was a frightening realization.
I like heroes.
Green light. I feel like the list of heroes and villains in my mind is long, and there are so many hidden, unlauded heroes. And there are even folks who might not top your hero list, but who did things with the power that they had and were able to make an impact. And we think about the Reagan era, and the Surgeon General during Reagan was C. Everett Koop. And in 1988, he did
Dartmouth grad.
he sent a booklet to every household in America about HIV, which was, in a way to answer the fact that the administration was so paralyzed. And so there are just so many ways in which that people do what they can with what they've got. And I mean, I even have examples. I've spent a lot of years as an AIDS treatment activist vilifying the pharmaceutical industry, but I can tell you that I know a lot of individuals who've done things like patent transfers to make sure that we can get these drugs out into the lives and the people who need them, not only in our country where people are paying ridiculous premiums for them, but in countries where they would never make it if the pharmaceutical companies that developed them actually had to produce them. So there are all of those kinds of stories. The other thing that I feel like is a really important piece of this whole story is the impact just HIV and HIV advocacy and HIV clinicians and researchers and all of the components, the impact that this particular disease has had on medicine writ large, on how we develop therapies, on accelerated approval, on expanded access, on how we do things, on universal precautions, on the ways in which we teach and learn and understand about the human condition, and is something that I think we sometimes miss. HIV is really, it's something that I feel proud about, is how much that the work that we have done and the experiences, the costs we have paid, have also significantly contributed to medicine overall.
I'd like to emphasize heroes as well, and just briefly, I guess, two, neither one of whom I've ever met, but one is the originator and then the many thousands of implementers, if you will, of the so-called PEPFAR program, or the President's Emergency Plan for AIDS Relief, PEPFAR, which I believe was started by President Bush around 2002-3. I think it was announced in the State of the Union address, I think in 2002. And it's made a huge difference in terms of people surviving HIV infection around the world. And that system for PEPFAR, and Lisa, you might want to add, but it's a gift that keeps on giving in terms of being used for later for COVID, for one of the first trials of a remdesivir drug, and for vaccine trials around the world. Even though we still don't have a safe and effective or licensed AIDS vaccine, HIV vaccine, I should say, or we still don't have a cure. I think I'll just stop there with one.
Okay.
Thanks.
That's good. I have quite a few more questions, as you might imagine, but I want to turn it over to folks in the audience, either online or otherwise. Love to hear some questions. What are some things that came up while you're listening to our guests? You're allowed to ask a question, Lisa.
I'll let others go.
Okay,
first.
great.
Yes.
Yes. Can we get a microphone? You have to be on microphone so they'll hear you online.
So that was great, and it was moving. I went to high school in San Francisco, and then started medical school in 1987 at UCSF, and was at San Francisco General. So just, by way of comment, one of the things that I think was really impressive during that time was what the gay community and broadly in San Francisco did. And I think you can see it in the way you were talking, that there was both, it was a horrible time, but you were seeing a lot of people at their best. Something you said made me think of the quote by Churchill, that sometimes it's not enough to do your best, you have to do what's required. And there were a lot of people doing what was required. And so in the midst of all of that, it was inspiring, and particularly at San Francisco General. As a medical student at the time, seeing a lot of people who were my age dying, seeing all the hemophiliac patients, just cut off, seeing the blood bank have to, majorly, where I almost got a transfusion when I was younger, so it was very overwhelming. And then coming back later as a fellow, and I was the attending at the HIV clinic for eye clinic, right as HART was coming in, and seeing that really transform. So a lot of the things you've said I can relate to. One of the things, the thing that has the most parallel for me now, what's going on now, I mean, COVID's an obvious parallel, but is the opioid epidemic. And it really cuts through all of medicine, and we see patients in the eye clinic with bad disease related to the opioid epidemic. And, things seem very, very dark, in the 80s, as you said. I don't know, and the idea that HIV could be a manageable disease seemed like a pipe dream back then. I don't know where things will get with opioids, but I wonder, and I don't know if the same community activism can emerge for that, because I think it's needed, and it's the thing to me that seems the most reminiscent of those times.
Yeah. Good.
Yeah, it's interesting that you mentioned that, because I was just reading, it was, I think, the Journal of Psychiatry, and it's hard for me to say because they said I don't remember the names of the authors, but it said you can reference this as long as you mention the authors, and I don't remember the authors. But the gist was that Larry Kramer did for every subspecialty of medicine. He did, Larry Kramer and Anthony Fauci and ACT UP TAG, Treatment Action Group, they created this fast track for testing, and that the one area, the one subspecialty of medicine where this isn't happening is psychiatry. And one of the biggest challenges with psychiatry is that patients' depression doesn't really make activists, Bipolar disorder doesn't really make activists, but there are so many potential treatments. There's MDM, there's psilocybin, there's that if there were an advocacy such as ACT UP, I mean, I don't mean to sound like a broken record, but it wasn't me who wrote the article. So I think that's really the problem with the mental health community and psychiatry. The challenge for psychiatry as a subspecialty is there aren't patient advocates, patient/advocates, not patient advocates, who are willing to do the sort of thing you did, to save your life and so many other lives. So I mean, that's just one response to that, which is a challenge. And as a mental health professional, it's like, all right, Winston Churchill, what did he say? It's time for me to step up, probably. Because I just read this article in prep for this.
Actually, I appreciate your point, because I had this conversation with a colleague earlier today, because I said I'm doing this panel and we're talking about physician advocacy and how important this, the impact, at least from my perspective, of the physician, clinician, whoever the other player is, stepping into the role of advocate. And we were kind of lamenting the fact that in many other disease areas and many other conditions, there's a dynamic that is that medicine knows the answer, and then the people come and you provide the care. And in HIV, medicine didn't know the answer. So there was this gap, there was this hole, there was this place for us to fill. And because I've pondered extensively, like, why don't we see advocacy in so many other areas? I mean, you specifically referenced deny, but I think in many, many other areas, we've tried to cultivate. I'm dealing with a number of family members dealing with severe cancers. And again, the advocacy in those realms is not the same. And I wonder if it was that there wasn't the room for that, because there were the people who had the answers and the people who needed the answers, but there wasn't this hole that we had in HIV in the beginning, which is that nobody had the answers and we had to fill it. And I don't know how we evolve to develop advocacy that is more effective and pervasive in all different areas in the absence of that gap, that hole.
You're an oncologist. How does that feel about that gap? Yeah. I know that is a hard question.
Yeah, no, it's an interesting point. I'm not sure I have a particularly helpful insight into that. I think a lot of these problems are fundamental scientific problems, right? And the solutions are scientific solutions that then have to be realized. So, I've always thought my own perspective on this is that, I've always seen myself as an advocate for the patient I care for, and that the real solutions to the problems are through the science, doing good, careful clinical trials, so I don't have anything else to say.
Well, Dan, you've been in many situations where the science might have been right there in other parts of the world, and you had to fight against non-scientific elements to advocate not only for your patients, but other folks around. Can you share the microphone with him? That combination of...
It's so hard for me to talk about Ebola 10 years ago.
Yeah, that's what I was thinking of, as you might imagine.
So many people died in Sierra Leone, Liberia, and Guinea. So many of my patients, more than 200 patients that I provided best possible care for, but it wasn't enough because we didn't have access to really basic treatments like fluid rehydration, sodium, potassium, glucose. no x-rays, no couldn't measure, blood tests couldn't measure any of those things, sodium, potassium, certainly no breathing machines, no kidney dialysis machines. But relative to the 28,000 people with Ebola that we know of, and there were probably at least twice that many in West Africa in 2013 to 2016, the probability of someone dying with Ebola in West Africa, including Nigeria, was much, much, much higher than the relatively small numbers of patients who were flown to Europe or to the United States for care, because just the grave, really horrifying inequities in the standard of care, what was available. I probably should just stop there. It still bothers me so much after 10 years. Honestly, when you were talking about the Reagan years or the people with power, I don't know. It's not exactly the same, but it's also not different. So many more of our patients in West Africa would have survived if we just had air-conditioned tents, because that's all we have is tents that were just sweltering hot. I mean, we had a lot of Stop there.
And to me, that's that dichotomy between the clinician and the advocate, because you're there to serve the scientific element that you're talking about and not give them the tools. These are not magical tools. These aren't new drugs. These are basic elements that for different political reasons were not available to you. I'm not making you talk about it. I feel so
I'm just saying that, I don't never really consider myself an advocate per se, although I worked
You're
with the
clearly,
FDA
yes.
in terms of vaccines, et cetera. But for HIV, but for Ebola, that's what I did for most of the last 10 years. Anytime, I lived in DC until 2 years ago, and I would talk, Capitol Hill, Georgetown, anywhere and everywhere. About how horrible it was, and it certainly didn't have to be that way. It shouldn't have been that way. It was horrible. I personally didn't have anything to do with it, but in the Eastern Congo, in the second largest Ebola outbreak ever, which was 2018-19, I'd say a world effort in the middle of the Eastern Congo, where there's a chronic civil war since 94, 30 years. Clinical trials were done that were deemed for an Ebola vaccine and for 2 treatments for Ebola, mostly for early stage monoclonal antibodies, that were deemed not only by African and European regulatory authorities, but by the US FDA to license an Ebola vaccine based on studies that were done in Guinea in 2014-15, but also in the Eastern Congo. So now there is an FDA licensed vaccine for one of the multiple strains, but the most common one of Ebola, and monoclonal antibodies, again, just for the Ebola Zaire, most common type of Ebola, not for other ones. But it's a huge start. It's a huge leap forward since the first Ebola outbreaks, and there's been over 30 of them now, but the first one was in 1976. 2014, 15, 16, we had nothing in terms of specific therapy, but now there is, in part because of the world's effort, with some contribution by the United States in the Eastern Congo, second largest epidemic of Ebola.
I am someone who looks at a platter of beautiful fruit and wants one of every single piece there. And that's what this talk has turned into, unfortunately for me. It has gone on much longer than we've discussed, and each one of you could be your own story here for 2 hours. And so I'm feeling bad that I want to wrap it up, but I'd love to wrap it up with your reflection, Dan, that there was nothing, and these baby steps that you all continue to fight for are what built what we have now, and we're going forward. And we've been talking about, what does it look like today for a Dartmouth student who might be diagnosed positive? What does that look like? What does it look like for someone who's looking to avoid infection, all those elements? And I just wanted to start by thanking the four of you for all the work you did so much. Thank you. I didn't get as many questions out as possible. I'm sorry. Please come to the front and ask. Mike got the only question. It was a good question. It was good. It got us going. Yeah, no. Please, thank you again. I really appreciate what the four of you are doing. And please take Dan's class, where every class will be like this, only shorter. Thank you again.